So when somebody presents to our hospital, typically they either come by themselves or by a family member or through EMS. EMS personnel then sends a message to the emergency room. I have a stroke patient coming. And that message is very important because that message then gets conveyed to the stroke team. We call that a pre-notification. That allows the team to get ready to respond to the stroke patient as fast as possible. So once the EMS brings the patient to the hospital, the team is already there, ready to start treatment. The team then meets the patient in the emergency room. And when it comes to stroke, parallel work is very important to save time. So we meet the patient, typically in the emergency room, to make sure the patient is stable. And if the patient is stable, the immediate thing we should do is take the patient to the CAT scan. We need to get the CAT scan to see what kind of stroke there is. Again, the patient is evaluated, scans are done, we determine if there is a bleeding or non-bleeding stroke. Following that, we determine if there is a blockage in a blood vessel. We call it a large vessel occlusion. That's typically done by CT angiogram. Again, it's very essential because remember, we have treatment available for those kind of strokes. Then the decision is, typically before the CTA, whether or not that patient can get thrombolytic. We need to know the certain risk factors, and then if the patient qualifies, the patient gets the thrombolytic. Then, if the patient does have a large vessel occlusion, patient taken quickly from the scanner directly to the operating room or IR room, where again the team meets the patient, anesthesia in addition to IR techs, in addition to nurses, get the patient ready. Then as fast as we can, we access the femoral artery, where with wire and catheters, we're able to then navigate through the carotid arteries and navigate farther, find out where the blockage is. As we find the blockage, then the goal is to remove the blockage. That thankfully can be done relatively fast, and we're lucky to have great technology to allow us to do that. After that, this is not finished because that patient again needs to be monitored closely. So the patient taken from the IR suite or OR up to the neurointensive care unit. Things to monitor are, for example, blood pressure, make sure that bleeding doesn't happen, and then they have to be started on some sort of treatment more often, like any kind of blood thinner, and any neurological changes we need to know because then we need to react or treat that. Following that, the patient is evaluated by the stroke team for secondary prevention and for other risk and treatment. The rehab, if the patient needs it, is also very essential, which then the patient is evaluated by our in-house team to see if they have need for rehab, whether or not inpatient or home. And then following that, the recovery continues. Then the patient needs to figure out, well, why did this happen to begin with, and do everything that we can to prevent that. We have a comprehensive stroke clinic where we see the stroke patients after they get discharged from the hospital, and we go through those things and work with them to try to prevent the stroke from happening. Obviously, this is not done without the help of primary care, other physicians, other providers, and their family.